Good afternoon. The prevalence of preclinical diabetic retinopathy dictated by optical coherence tomography angiography (OCTA) among type 2 diabetes mellitus patient with no clinical diabetic retinopathy. Introduction. Diabetes mellitus is a global public health problem, and one of the most common complications of diabetes is diabetic retinopathy, which is a progressive microvascular disease that can lead to vision impairment and blindness. A 3D imaging technique called OCTA allows non-invasive visualization of the retinal microvasculature without the need of dye injection when compared to FFA. And the features of preclinical retinopathy that cannot be seen on fundus examination can be identified by OCTA. Coming to the objective, the aim of the study is to find out the prevalence of preclinical retinopathy dictated by OCTA can be used in the early diagnosis of diabetes in patients with no clinical retinopathy using parameters like vessel density, foveolar vascular zone, microaneurysm, and capillary dropout area in patients with type 2 diabetes mellitus attending IOPD in a tertiary care center. And coming to the methodology, it was a hospital-based cross-sectional study in a IOPD of a tertiary care center, following 1 year from approval from IEC. Coming to the inclusion criteria, type 2 diabetes patient with at least 5 years of diabetes, but no signs of diabetic retinopathy of age group 30 to 60 years. And coming to the exclusion criteria, evident diabetic retinopathy changes were excluded, and type 1 diabetes and age group out of these group and other diseases like glaucoma, high B. Coming to the sampling method, it was a non-probability sampling method, and study variables was age, sex, DM duration, treatment, family history, FBS, visual acuity, and fundus examination by 90D, and OCT findings. And my sample size was 125 eyes. Coming to the results. In my study, majority are the males when compared to females, and it was a relatively balanced gender distribution. And coming to the age group, majority were in the age group of 50 to 60 years of age. And duration, majority were in the duration of the diabetes less than 10 years, indicating a relatively early stage diabetic population. And vessel density, decreased vessel density is a sign of reduced perforation, and significant vessel density decrease in the central and the outer zone, but no strong correlation was there in the inner zone. And coming to the foveolar vascular zone, and foveolar vascular zone circularity shows a significant p-value and statistically significant evidence indicating the remodeling of the foveolar vascular zone, but no significant correlation for foveolar vascular zone area and perimeter with DM duration. Coming to the microaneurysm was present in 80% of the patients, indicating early microvascular changes. Capillary dropout area, 24.8% of patients shows capillary dropout area, indicating early ischemic changes. And coming to the association between the duration of the diabetes and microaneurysm, majority of the patients have diabetes for less than 10 years, and no significant association was found between the diabetes duration and microaneurysm presence, indicating that some other systemic factors like HbA1c level, blood pressure plays a critical role in microaneurysm formation. Coming to linear regression of duration of diabetes with vessel density, the outer circle vessel density shows a significant correlation with diabetes duration and was statistically significant, shows an inverse relationship between the duration of the diabetes and vessel density. And conclusion, it confirms the high prevalence of preclinical retinopathy based on 80% of the microaneurysm present, and approximately 25% of patients have capillary dropout area, suggesting progression towards clinical retinopathy and supporting the hypothesis that chronic hyperglycemia lead to progressive ischemic damage. The vessel density decrease suggests early stage microvascular impairment, which indicate preclinical damage before the diagnosis of diabetic retinopathy, and provides a detailed regional analysis of vessel density and foveolar vascular zone, which is not always explored in previous studies. And my studies confirm that longer diabetic duration is associated with significant retinal microvascular changes, including the vessel density reduction and foveolar vascular zone remodeling. Dictating these changes at an early stage can help to implement timely interventions to prevent the progression to diabetic retinopathy before clinical retinopathy manifests. It highlights the importance of early OCTA screening in diabetic patients. Therefore, OCTA is highly sensitive in detecting early microvascular changes in diabetic patients who show no clinical signs of diabetic retinopathy. Coming to the limitation, it was a cross-sectional design, so no longitudinal follow-up was used to assess the progression of the disease, diabetes, and absence of control group, and it was a small sample size, and lack of systemic biomarkers like HbA1c levels, lipid profile, and hypertension status could help to correlate systemic factors with retinal microvascular and poor octa image quality in cataract patients. And these were my reference.
Intervention is in that stage only when NPDR becomes PDR. So probably that transition phase is the key phase. Trying to find out whether a person who is not seen diabetic retinopathy, you will not see diabetic retinopathy, but you pick it up with octa, will not have any value, because mostly it will be like conservative management and control of diabetes, which is already being done, even otherwise being done. So probably that is the key point. And second point is I can't accept like opta against clinical examination. You are trying to say like opta against fundus photography. I think it should be opta against FFA. So that you can say like in these vessel density losses, can you corroborate it with any of the FA findings? Or can you pick up early macular edema? These things will be like more valid than this. So please try to look at that angle also, and try to look at from NPDR to PDR going. Can opta pick up an ILMA or something far early than a NPR also? That will be having more value.
Only one suggestion, Sruthy. Presentation is nice, but you look at your title. Your title says prevalence of
Preclinical.
So, but where was the prevalence?
Prevalence was calculated based on these parameters.
Your conclusion should highlight that. Right? My point is you explored a lot of things. That's fine. But when you are quoting it in your title, the prevalence of the study, then you should focus on that and discuss on that. This was the prevalence in my study. Right? And second thing, do you think you can assess prevalence in a 1 year study?
No, it was one of my limitation of the study.
So the term prevalence should be used carefully, especially for demographic study. If it is a 1 year study, you can quote incidence. Incidences per year. Prevalence is over a period of time the disease presence in a population. Okay, so just change your title when next time you are presenting the study.